Good morning, everyone, and thank you so much for coming to our hopefully exciting and rewarding day today here. We're very proud to start our inaugural meeting. We're hoping to have this run on a yearly basis. And it's about our multidisciplinary approach to metabolic syndrome. We've arranged a star member of speakers today, all of whom are Baylor faculty. And we have an in-person audience here in our Cullen Auditorium. If any of you are interested in joining us, please come in. And of course, we have our virtual audience over the internet who are attending this talk. We're also really very appreciative of the support that we're getting from Medtronic. Thank you so much for providing us with a unrestricted educational grant that really has allowed us to offer this educational event without any charge and for free. And I really appreciate your strong support in advancing our mission. Thank you so much to Medtronic. All right, we are going to have a series of presentations. We've divided them into segments. We're going to have a panel discussion after a few presentations. So please hold your questions until then. And we'll have the speakers come up here on the stage during the panel discussion to answer all your questions. There are microphones here in the room for you to use in person. And for those of you who've joined us virtually, please enter your questions into the chat box, and we will be monitoring it and presenting your questions to the speakers and the audience. All right, without further ado, I forgot to introduce myself. My name is Dr. Samer Matar. I'm professor and chief of the Metabolic and Weight Loss program here at Baylor. And I am going to kick it off with a presentation about the epidemiology and pathophysiology of metabolic syndrome. So this is my disclosure, which really is not going to influence the presentation in any way. Let's start off by the definition of metabolic syndrome. I'll tell you, this has been a moving target to some degree. The definition has been evolving over the years. And most recently, the most current definition of metabolic syndrome is also named the harmonization definition because it brought together prior definitions together to the current one. And this is a definition that was created by a conglomerate of relevant organizations, including the International Diabetes Foundation, NHLBI, the American Heart Association, World Heart Federation, and so on. And you can see the table on the right here. It designates all the different measures or parameters that we measure and the risk factors. And any 3 out of these 5 risk factors in the table, if they are present in the patient, they qualify or help reach the definition of metabolic syndrome. Elevated free fatty acid levels and abnormal adipokine profiles are characteristic of this disease. And of course, insulin resistance appears to be a common central component in this disease. The prevalence has been rising. I think this is no surprise to anyone in this room. And not only does it rise among the population, but its incidence increases with age among individuals. It's highest among people of Hispanic ethnicity, and there are other special populations that have a higher incidence of metabolic syndrome, such as the American Indian, Asian Pacific Island, in higher rates than those of European descent. And what we're finding also is that this phenomenon has been rising in developing countries. So you're probably familiar with these maps that are issued by the Center for Disease Control in Atlanta. They're basically representing the results of telephone surveys that are conducted every year. They have a bank of operators who call people randomly and ask them what their height and weight is, and based on that, they calculate the respondents' BMI, and then create these maps according to the percentage of patients or people whose BMI is above 30, meaning obese, in different states. And this was the situation in 1991, where the states colored in blue were those that had more than 15 to 20% of their population whose BMI was above 30. And then we jumped to 2011, and there are no more blue states. They're all shades of brown or even red in 2011. And then a decade after that, you can see it's markedly increased. So I think this very nicely shows us how the incidence of obesity has been spreading almost like wildfire. And this is the most recent one, showing how it disproportionately affects non-Hispanic Black adults as well in these states. And this is for the Hispanic population. Interestingly, they also did a similar study measuring or calculating the incidence of diabetes in the United States. And you can see this is the situation in 2004. We jumped to 2019. And so you can see from that how you can pretty much almost superimpose the maps of diabetes and obesity on each other, and they will correlate. As for our state of Texas, these are some pretty sobering numbers here that show how the incidence of obesity affects 28.5% of Texans, Texan males, and 30% of females. And we are proudly ranked as number 13 in adults with type 2 diabetes and 10th in obesity. And you can see the economic or financial numbers that are associated with this disease. So as I'll mention later today, it's not it's quite an expensive disease to have. And then this breaks down the different regions in Texas to see where the predominant prevalence of obesity is. And you can see where we live here in the Houston area is about 43%. So what about in the United States? I don't know if you're aware, but there's an interesting website that actually counts our population in real time. And I accessed this on May 12th, and the US population was 334 million, as you can see there. And we know that the obesity rate in the United States is 40%, which calculates to 133 million people in the United States are obese. And in terms of severe obesity, meaning BMI above 35, we know it's 9.2% now, which is up from 6% just a few years ago. And that calculates to 30 million people in the United States have obesity, severe obesity with a BMI above 35. Quite sobering numbers. And not only that, I mean, we don't see any inclination for this high rate to stabilize or drop over the next few years. In fact, there are many organizations that have already predicted that by the year 2030, it's going to rise, as you can see from this table here, a continuous rise to reach 50% of the US population will be obese, 50%. Now, this is not an American phenomenon. This is a worldwide, global phenomenon, as you can see from this map here. All these countries that are shaded in dark green have very high obesity rates in adults as well. And even in developing countries, this is happening. This is a WHO map of obesity in male population across the world. You can see certain shades of green depicting the penetration of obesity in these countries. And this is for females. Especially, you'll notice in the Middle East and the Gulf area, there are countries like Kuwait, where almost 80% of their female are obese. Sadly, it's affecting not only adults, but also children. We have been seeing a very alarming rise of obesity in children. I hear many pediatricians are baffled at how they're having to treat adult-type diseases in children, such as sleep apnea, diabetes, and hypertension. And you can see here there's been no more than a threefold increase in obese children from 5% to almost 16% over the last couple of decades. And the problem with having obese children is that many of them become obese adults, so that by the time they reach young adulthood, meaning in their 20s, they already have or present with very advanced medical conditions such as renal disease and liver disease. And this graph shows you that almost 80% of overweight children become overweight adults. The problem is, it's obviously, and I don't need to tell this to this audience, that having obesity is not just a matter of physical weight. These are metabolic problems, and this affects or results in multiple life-threatening diseases, which ultimately shorten people's lifespan. And you can see from this graph here that by the time patients reach or exceed a BMI of 40, their risk of mortality rises exponentially. And as a bariatric surgeon, I can tell you the majority of my patients, their BMIs are above 40. So this is the burden of being obese or super obese. By super obese, probably a term that's a little, should probably not be used now. It shows that in individuals with BMI over 25, every 5 units of BMI is equivalent to a 30% higher mortality rate. Again, sobering numbers. And there are other burdens that these patients face. As you're all familiar with these, these patients have a higher incidence of mental health, and we're not sure if the mental health disorders how they're related to obesity, whether they bring on obesity or vice versa. There's a higher incidence of substance abuse, eating disorders, and low self-esteem and socioeconomic hardship, to name just a few. Very briefly, I'm of course not going to go into all of these conditions, but this shows you how obesity and the metabolic syndrome affect globally people who are threatened by this disease. I was told when I was in the beginning of my career by Harvey Sugarman, one of my mentors, that obesity affects people starting from the head to the toes and affects every organ in between, as you can see here. And these are all serious life-threatening diseases. And that is because we've learned over the last 2 decades that adipose tissue, we used to think is probably just cells that store fat and are silent, are anything but silent. They are very active factories, if you will, or warehouses that secrete multiple chemical agents that can be very injurious and damaging to the rest of the body. And these are just a few of them that we've come to recognize that affect our immune system, our skeletal system, our organs, and so on. And if you were to try and classify all the complications of obesity and metabolic syndrome, you might want to categorize them in the following way: metabolic, structural, degenerative, and so on. But you can see from this how widespread and life-threatening this can be. This is a graph, it's a little dated now, that shows the incidence of life-threatening conditions that are associated with obesity. Of course, one of the main ones is type 2 diabetes, probably related to insulin resistance, and it can affect up to 60%. I can say in my clinic, we see about 30 to 40% of our patients have diabetes. And of course, there are other comorbidities, as you can see there. And this is, again, the relative risk of type 2 diabetes in women according to BMI. And look at the BMI line there, 35, and you can see it's already, the relative risk has approached 100%. And again, we see patients, all of us here, that have much higher BMIs than that. And this is the problem with diabetes, that the prevalence of it is rising at exponential rates. At least 30 million people in the US have diabetes. If you were to include pre-diabetes, that's almost 100 million people at severe cost to themselves and to the nation at large. And you can see there's been a lot of discussion about treating insulin and treating diabetes with insulin. That itself constitutes a major portion of healthcare costs. Another small bit of information here is that for every elevation of A1C of 1% is equivalent to 1.4 rise in the risk of severe complications of diabetes, which is why we try to, as much as possible, control diabetes, especially with regards to their A1C, and there are some nice calculators that are available to help us do that. Another emerging life-threatening disease is fatty liver disease. And this is essentially the deposition of lipids in hepatocytes. And over time, in the absence of alcohol intake, this is the definition of non-alcoholic fatty liver disease. Again, it's prevalent in epidemic proportions, and we're seeing this in rising incidence in the United States and across the world. There is a spectrum of diseases that is related to fatty liver disease. Once inflammation sets in, then you get NASH, non-alcoholic steatohepatitis, which can itself then advance to cirrhosis or even hepatocellular carcinoma. And cirrhosis can lead to life-threatening conditions like portal hypertension and liver failure. And if you recall, I mentioned about how this phenomenon is rising in children. And we've now, over the last decade or so, we've been seeing that liver transplantation in adolescents and young adults has been rising in tremendous rates. And it's one of the, and NASH is now the major or the most common indication for liver transplant in young people. Once again, this diagram depicts how simple steatosis or fatty liver disease can progress over time, especially if NASH sets in, which it does in about 20% of people with fatty liver disease, to these more serious conditions. And again, the problem is that it can result in cirrhosis requiring either liver transplantation or hepatocellular carcinoma. However, it's not all bad news, because we found that fatty liver disease is reversible with weight loss, by whichever means, whether it's pharmacological weight loss or surgical weight loss. And this shows some histological findings from a study that I was involved in, where we took serial liver biopsies in patients at baseline and then after surgery. And this shows you here nicely how in the fatty liver disease, the different stages of it from fatty liver, and you see in steatohepatitis how inflammatory cells set in, and then the fibrosis sets in and causes cirrhosis. We've tried to understand better what it is that causes this inflammation in liver and in liver tissue and liver parenchyma. And we found that there is a link between fatty liver disease and sleep apnea. As you know, in sleep apnea, there are these multiple episodes of chronic intermittent hypoxia, which create gene expression induction, and this can lead to inflammation and then NASH and progression of the disease. And talking of sleep apnea, I'll very briefly touch on this. This affects 7% of the general population. Its incidence in obese patients is 45%, probably higher, and it has associations, as I mentioned, with GERD, NASH, and type 2 diabetes. And it's important, if we are going to operate on these patients, that these conditions be optimized. And we feel that adipocytes are the link between all these diseases. Again, the inflammatory cascade that happens once they are stimulated, and they can even result in gastroesophageal reflux disease, which we see quite commonly in these patients, that itself results in microaspiration of acid contents, causing inflammatory responses in the lung. Many of our patients present with heart failure of varying degrees. And again, there's a complex relationship between obesity and heart failure. Obesity can affect hemodynamics, hypertension, changes in systemic mass, blood volume, and so on. There's left ventricular hypertrophy, left atrial enlargement, and the insulin resistance that's present in most of these patients reduces the uptake of glucose in cardiac cells and results in mitochondrial dysfunction, and the end result is cardiomyopathy. And in fact, we do see many patients who come to us on left ventricular assist devices or other treatments to sustain their hearts for treatment. And in these patients, weight loss really is, just like in fatty liver disease, the only effective long-term treatment for obesity cardiomyopathy. And for many of these patients, they end up needing surgery in these high-risk patients. We also see a very large proportion of renal failure in these patients. This is the results of a study that interrogated the ACS-NSQIP database, which is a national database. It included 138 patients, and they received different operations, as you can see there, the band, gastric bypass, and sleeve gastrectomy. Their mortality rate was 0.7, morbidity 5%. And so this shows you that even though these patients have end-stage disease, they can be treated through surgery if optimized and have good outcomes. Very briefly, I'm going to talk about GERD, and there is again, a worldwide rise in the incidence of GERD, and we feel in many cases it is related to obesity. And you can see here that the obesity raises the odds ratio for GERD by 1.74, and that every gain of 5 kilograms is equivalent to 2.7-fold higher risk of GERD in these patients. And these are the various causes of GERD, but most importantly is the increased intra-abdominal pressure. And then finally, just a word on cancer. We have been seeing over the last few years that there's a stronger association between obesity and cancer, especially the ones depicted here. There are several agents that have been found to be an association between obesity and cancer. And we found that weight loss actually helps prevent future cancers in some populations and increase survivorship in those who've had it. So in summary, the obesity epidemic continues to relentlessly rise. The rate in the United States is 40%, and we're expecting it to reach 50% by the year 2030. Alarmingly, it's rising in children and adolescents at unprecedented rates, and it is associated with multiple life-threatening conditions. So I think I forgot to start the timer. I'd also like to take this opportunity to mention I have two wonderful co-directors for this meeting, Dr. Yang and Dr. Olodunjoy. Thank you so much. And now I'll ask my next speaker to come up, and that will be Dr. Vani Putluri. Dr. Vanni is a faculty here at Baylor. She is an assistant professor at Baylor College of Medicine, and she is going to talk to us about the medical components of metabolic syndrome. Thank you.
Thank you, everyone. My name is Vani Patluri. I work in the General Internal Medicine Department at Baylor College of Medicine. So we're going to jump right in. So I just wanted to say no disclosures at this time. So we'll go ahead and jump right in and talk a little bit about how complex and multifactorial metabolic syndrome is and how the management is guided by some of the other medical components. And so the first thing that we're going to talk about is about the genetic, endocrine disorders, debility, and nutrition and medication-induced components that can kind of complicate metabolic syndrome. And then, of course, there's psychological components as well. And I'll defer the majority of this evaluation and treatment to Dr. Brown's upcoming presentation, but basically, it is very important to take these into account. So we're going to talk about genetics first. So there are numerous genetic disorders that can predispose patients to pathologic levels of weight gain and metabolic syndrome. Now, most of the genetic syndromes and disorders tend to be polygenetic, and so they don't tend to be multiple single genes or syndromes that we see in the adult population. But there are isolated, genetic syndromes that are very high risk in the pediatric population, and we do sometimes see these adult patients as well, patients with Down syndrome, with POMC, leopard deficiency, things like that. But most of the time, we're seeing the end results of having multiple genes that are working on a person to cause metabolic syndrome and its complications. So we're going to talk about endocrine disorders. So endocrine disorders are very important because when we're talking about patients with metabolic syndrome, it's really important to identify other things that are complicating the patient's care. And we really want to make sure that we address any of these underlying disorders in order to assist them in successfully losing weight and reversing their metabolic syndrome. So we do see things like growth hormone deficiency, although these tend to present more in pediatric populations. We can see high cortisol or Cushing's, although this tends to be a very rare diagnosis, but it is important to consider if you have a patient with pathologic weight gain. We also have to consider thyroid states because low thyroid state can also make it very difficult for weight loss, especially because it's a huge metabolic contributor. And then, of course, as Dr. Matar mentioned multiple times, diabetes and insulin resistance is a huge underlying component to metabolic syndrome and weight loss and difficulties in losing weight. We also have seen an increasing rise in the diagnosis and popularity of management of sex hormone deficiencies. We see this in men with male hypogonadism with low testosterone, and we see this in women with menopause or early menopause with low estrogen states, and these can all affect the metabolism as well. We're seeing with the rising popularity of sex hormone replacements, we do have to be careful and make sure we monitor for side effects and complications, including the higher incidence of cancers and clots that are associated with hormone therapy. So the next thing that I wanted to talk about was nutrition, gut health, and metabolic health. So basically, as I think most people in this room know, nutrition is just not about the calories. It's really, the gut is a very complex system, and the ratio of macros matters, and this is why it's so important to get our nutrition and dietitian colleagues on board, because this is an essential component of losing weight and maintaining our healthy weight after we lose weight. Now, the gut microbiome is becoming more and more popular, and I have patients who come in a clinic and say, what about my leaky gut? How can I work on this? And there's no pill, there's no prescription that we can do. It really takes a lot of hard work, and we're still in the early phases of this, but I always like to harp on fiber because fiber is a prebiotic. It helps your gut maintain healthy bacteria. Now, there's been several studies that show that the gut microbiota, or the bacteria in non-obese or normal BMI patients versus patients with metabolic syndrome or obesity, tends to be different. And we do see increases of certain less beneficial bacteria in patients who have metabolic syndrome. And these bacteria actually directly contribute to insulin resistance, can raise your cholesterol number. So these are directly impacting the development and maintenance of metabolic syndrome. And so the important thing to note is that these microbiomes are not in stasis, And modifying the diet and adding in these prebiotics and working on these things and working on weight loss can actually help change the gut microbiome in more beneficial ways. So the next thing is I want to talk about is about debility and physical disabilities. So this is something that Dr. Cortez is going to talk about a little bit more later in this conference, but it is very important to keep in mind that our patients who have elevated BMIs, who have metabolic syndrome, often have complications, exactly like Dr. Matar mentioned. So people will have strokes, they will have cardiovascular complications, they will have early osteoarthritis. And so this leads to debility and inability to engage in exercise, which is a core component of metabolism and weight management. And so you have to have a very holistic approach. You have to make sure that if there's decreased mobility, we give our patients the resources in order to help them mobilize. And so whether that means home health, physical therapy, whether that means aquatic therapy if they can't tolerate land physical therapy. And in patients with cardiopulmonary complications, we need to realize and utilize pulmonary rehab and cardiac rehab in these patients so that we can help work on this in a holistic manner. So another thing that I want to talk about is medication-induced metabolic syndrome and worsening of pre-existing metabolic syndromes through medications. Now, I don't want to vilify medications because it's very, very important to realize that we don't want to leave disease processes untreated. Like an example of this would be lupus. If we don't treat lupus, it can progress to renal failure, strokes, and death. Those are much worse outcomes than the development of metabolic syndrome and are not reversible as much. And so we don't want to vilify medications, but we have to be aware that when we use certain medications, there is a risk of worsening metabolic syndrome, of gaining weight, and that means we have to monitor closely. And this is a very collaborative effect. We have primary care doctors, we have subspecialists all paying attention to this, and we intervene more aggressively if we need to in these populations who need to be on these medications. And so there's numerous medications that are implicated in weight gain. Steroids are very popular to villainize, but are also very important in the management of what they do. But judicious use is important. Now, the next thing that I want to talk about, and this is going to kind of segue into our next presentation, is that mood medications are very, very important, but some of them can have side effects, including weight gain. And there's certain medications that we use specifically to cause weight gain. So Remeron or mirtazapine, which we use for depression, is actually used to help cancer patients gain weight when they have no hunger, when they have no appetite. But sometimes it might not be the right choice in first initial choice anyway, in a patient who already has metabolic syndrome or an elevated BMI. We also have certain antipsychotics that can be more likely to cause weight gain or metabolic syndrome. Seroquel can cause more weight gain. Zyprexa can cause more diabetes, hyperlipidemia. And so these are things that we have to keep in mind. And when we have a patient with metabolic syndrome, we might talk about one of their alternative cousins, which is gentler on the metabolism. So things like Abilify or aripiprazole. So just thoughts that we have to keep in mind. When we treat a patient, we're treating the whole patient, and we want to make sure we're treating both the physical and mental components of everything that's going on. The other thing is diabetes has come a long way, and in the last several years, we have had increasing availability of medications that have multiple benefits. But in the old days, diabetes really only had a few agents. We had insulin, we had the sulfonylureas, we had pills that most of them have a positive weight effect. So they cause weight gain, which causes worsening metabolic syndrome, which causes worsening diabetes in some cases if we don't keep things in check. Now, we're not going to avoid treating diabetes because the complications of diabetes, as discussed by Dr. Matar, include heart attacks, neuropathy, kidney, eye manifestations. We don't need to be blind, dead, or have a heart attack, right? But we have better options now. And so, with the GLP-1 agonists, with DPP-4s, with our SGLT2 inhibitors, we have medications that not only keep the weight stable, that don't cause you to gain weight, but also help with weight loss and help potentially reverse diabetes, especially in type 2 diabetes. Type 1 is a whole nother ballgame. So we're going to keep on going and talk a little bit, segue into mental health and metabolism. The reason why it's so essential to treat the mental health component of these disease processes is because they intrinsically impact our metabolism. So mood, stress, and sleep are very, very important to how we gain or lose weight. And so with disordered mood, we can have impacts on appetite and cravings. We can have binge eating. We can have sleep issues. We can have stress issues. And energy to participate in healthy habits is not there. You know, we're tired, we're in bed, we feel down. And so it's very important to work on these things. The other thing is that some of the medications that we use specifically work on the brain and the mood to help with weight loss. So an example of this is Contrave, and I'm going to let Dr. Yang talk about all the different options we have for medically managed weight loss later. Other things is that stress can trigger cortisol release. It can increase visceral fat gain, and it increases glucose intolerance. And so these are the things that we need to keep in mind. This is a very holistic process, and insufficient sleep has been associated with increased appetite and insulin resistance as well. So in summary, weight management in the setting of metabolic syndrome is not one size fits all. It has to be catered to the person who's sitting in front of you, and it requires a multidisciplinary approach with medical evaluation to rule out endocrine, genetic, and medication-induced etiologies complicating the weight. And we also need to work on nutritional components and have continued support and guidance. And we need to make sure that we have fitness goals and realistic fitness goals with good, appropriate support. So, I really appreciate, all of you guys for being here today. And I'm going to let the next presenter come up. So, Dr. Brown.
Thank you so much, Dr. Polari, for a great talk. So it's my pleasure to introduce Dr. Brown, just assistant professor and clinical health psychologist, Baylor, and she'll be talking about psychological components of metabolic syndrome.
All right. I'm thankful for the opportunity to be here this morning and speak with you about the psychological components of metabolic syndrome. And I have nothing to disclose. So over the next 15 minutes or so, I'll try to go kind of as quickly as possible. I'm going to start off by describing the association between psychiatric disorders and mortality in general, before reviewing the relationship between metabolic syndrome and specific psychiatric disorders. So I'll cover depression, bipolar disorder, schizophrenia, and anxiety. Next, I'll review the research on the relationship between metabolic syndrome and perceived stress and hostility. Possible explanations for these relationships will be introduced, and I'll end by highlighting some targets for risk reduction. So in general, patients with psychiatric disorders are at a greater risk for mortality when compared to the general population. When we take a closer look at what's driving this risk, we find that about 60% of excess mortality in this group can be attributed to physical conditions, so including cardiovascular, metabolic, and respiratory diseases. The figure here comes from a 2018 study that looked at premature mortality among 4,000 people with severe mental illness in Wales between 2004 and 2013, using linked primary and secondary care data. The proportion of deaths by underlying causes are shown in the outer ring, with the corresponding standardized mortality ratio in the inner white ring. So according to these data, 28.4% of deaths over the study period were attributable to circulatory diseases, which corresponds to a standardized mortality ratio of 2.2. So when it comes to specific psychiatric disorders, there appears to be a modest association between depression and metabolic syndrome, and this relationship appears to be more salient among females versus males, and there's some evidence of differences based on symptom profile. So people who present with atypical depression, which is characterized by mood reactivity, so temporary positive mood in response to positive events, increased appetite, increased sleepiness, and sensitivity to rejection, for example, have been shown to have significantly higher rates of inflammatory markers, higher body mass index, waist circumference, and triglycerides than those with melancholic depression. So kind of the low mood, loss of appetite, difficulty sleeping. Some research is suggestive of a dose-response effect, and longitudinal studies are suggestive of a bidirectional relationship, where depression predicts metabolic syndrome and metabolic syndrome predicts depression. In patients with bipolar disorder, the rates of metabolic syndrome are almost 2 times higher than those in the general population. Specific components of metabolic syndrome found to be associated in this population include increased BMI, glucose, total cholesterol, and LDL cholesterol, and decreased HDL cholesterol. A similar relationship has been found between schizophrenia and metabolic syndrome, with increased odds of abdominal obesity, hypertension, low HDL, and hypertriglyceridemia. The extent of the metabolic disturbances seen appears to be greater with greater duration of illness, multiple episodes of schizophrenia, and age. In terms of specific disorders that fall under this spectrum, the relationship appears to be stronger in patients diagnosed with schizoaffective disorder versus, frank schizophrenia. The relationship between anxiety and metabolic syndrome is slightly less clear. So while one 2017 study provided evidence of a weak association between the two, longitudinal results are mixed. Two of the studies that were included in that 2017 meta-analysis did not confirm a prospective relationship, but a 2002 study evidenced increased anxiety across a 7.4-year follow-up in middle-aged women who presented with metabolic syndrome at baseline. And notably, the Attica study, which was a prospective cohort study that ran from 2002 through 2012, supports a relationship between irrational beliefs in the development of metabolic syndrome, particularly in the context of high anxiety. In terms of other psychiatric disorders, so rates of metabolic syndrome in patients with post-traumatic stress disorder versus the general population appear to be 1.82 times higher, and 1 in 5 patients with a diagnosed alcohol use disorder also meet criteria for metabolic syndrome. Psychological, psychosocial, or perceived, it's noted in a lot of different ways in the literature, is another factor that has been linked to metabolic syndrome. So it can be defined as a perception of mental tension, strain, or pressure that's caused by a difficult situation. Common psychosocial stressors include low socioeconomic status, interpersonal conflict, stressful work environments, lack of adequate social support, poor work-life balance, caring for a sick loved one. The Whitehall 2 study was a prospective cohort study of over 9,000 UK civil servants beginning in the mid to late 1980s. In a 2011 follow-up study, men and women who reported long-term conflicts in their relationships or lack of support in their closest relationships at phase 1 and 2 of the study, which was between 1989 and 1990, were more likely to experience an increase in waist circumference and BMI in phases 2, so from 1991 to 94, and phase 5, 99 to 90, or 97 to 99. And this was even after adjusting for demographics and health behaviors. Racism may also be considered, obviously, a chronic stressor. In a 2020 study involving structural equation modeling, interestingly, neither race nor self-reported racial discrimination were found to have direct effects on metabolic syndrome level. However, they were found to exert an indirect effect via socioeconomic position. And so this just really kind of goes to provide extra evidence for the fact that low socioeconomic status is associated with chronic stress. And there's a great deal of support for the relationship between socioeconomic status and disease and mortality, and this is commonly referred to as the status syndrome. In 2019, Kuo and colleagues conducted a systematic review and meta-analysis to really kind of further examine the effects of different sources of stress on metabolic syndrome risk. And after controlling for possible covariates, adults in the high stress group had a 45% higher chance of having metabolic syndrome than those in the low stress group. So that corresponds to an odds ratio of 1.45. When they compared the effect sizes among sources of stress, they found that occupational stress had the largest effect size, and this was compared to general kind of life events and general perceived stress. Hostility is another factor that's been linked to metabolic syndrome. So as a broad psychological characteristic, it can be broken down into affective, behavioral, and cognitive factors. The affective and behavioral factors, which encompass frequent experience of anger and aggression, can be referred to in combination as expressive hostility if you're looking at it from a kind of two-factor solution. And then there's cynicism or cognitive hostility. So when hostility is defined as expressive versus cognitive hostility, the research findings, again, are kind of mixed. So in a 2020 study, support was found for a relationship between expressive hostility specifically and metabolic severity and waist circumference, particularly among females, whereas the relationship between that cognitive component or cynicism and metabolic syndrome was not significant. The relationship between anger specifically and metabolic syndrome appears to be bidirectional. So in a series of studies, baseline trait anger was found to predict risk for the development of metabolic syndrome, and baseline metabolic syndrome predicted increases in trait anger at both 2 and 15-year follow-up. And there are several different pathways that have been proposed to explain the relationship among these psychological factors in metabolic syndrome. The first of these involves unhealthful lifestyle behaviors that tend to be prevalent among patients with psychiatric diagnoses and those with metabolic syndrome. So things like smoking, excessive alcohol use, unhealthful diet, sleep disturbance, physical activity, poor adherence to medical regimen. In terms of physiological dysregulations, the link between both oxidative and perceived stress and metabolic syndrome is thought to be attributable to overactivation of the stress response and the associated axes. Chronic stress may facilitate low-grade activation of the immune system and inflammatory response. It's also known to promote increased consumption of highly palatable foods and visceral fat storage. There's also evidence of shared genetic vulnerability. So a recent review identified 24 genes that appeared to be shared by mood disorders and cardiometabolic conditions. And so this includes things like FTO, so encoding fat mass and obesity-related protein, and IGF-1, so encoding insulin-like growth factor 1. Shared genetic pathways involve serotonin and dopamine receptor signaling, circadian rhythm signaling, and leptin signaling. Alterations in gut microbiome have also been posited as a potential link between metabolic and psychiatric health, and I'm sure we'll see much more kind of research coming out in this area over the next few years. And psychotropic medication, which of course was already mentioned, is another possible pathway. So there's significant evidence linking certain classes of antidepressants, so specifically tricyclic antidepressants and SNRIs to weight gain and hypertension, and then certainly the atypical antipsychotics, especially clozapine and olanzapine, have been linked to weight gain, abdominal obesity, insulin resistance, and altered glucose and lipid metabolism. So in addition to promoting improved diet, sleep, physical activity, programs to facilitate smoking cessation and improve medication adherence may also be beneficial. Other factors that we want to make sure to consider are psychosocial stress and mood. So skills such as, deep breathing, meditation, mindfulness, cognitive restructuring, problem solving may really help patients more effectively manage stress, anger, or depression. And we should always really seek to promote and strengthen our patients' psychosocial resources, so including positive social relationships, work-life satisfaction, personal growth, resilience. These are all things that can certainly reduce risk. So in sum, there are various psychological factors linked to metabolic syndrome, and their relationship, at least for some, appears to be reciprocal. Though there is certainly a need for more longitudinal research, it may be most accurate to really consider metabolic syndrome as a combination of biological and psychological risk factors. From a practical perspective, this highlights the importance of screening for both medical and psychological factors that can contribute to the development of metabolic syndrome. And so traditional behavioral interventions to facilitate healthful lifestyle behaviors, including diet and physical activity, improved sleep, may certainly be effective in reducing both the psychological symptoms and the risk for metabolic syndrome. But we also need to certainly, address stress and mood as needed, given the links that we've seen between these factors and metabolic syndrome. And so, of course, I think as is the theme today, enhanced treatment outcomes are most likely in the context of taking a multidisciplinary approach. Thank you.
In regard to the, Dante Milton with Medtronic. Happy to be here. Thanks for putting this on. This is amazing. In regard to the antidepressants, we're talking about Remeron and some of the other medications. I'm just curious as far as the gray area, what's that balance between understanding when and when not to prescribe and just trying to understand that a little bit more, considering, it could definitely contribute to weight gain. And of course, we're trying to prevent those patients from getting there. A lot of times they're already depressed because of weight gain. So it's kind of contradicting to an extent. So just curious, how do you tread that line finally?
So I'm not a psychiatrist, so I don't prescribe medications. But certainly if we have patients who are in our program and are seeking bariatric surgery and are struggling with mood, there are certain antidepressants, right, that have kind of a more positive profile when it comes to weight. So like Wellbutrin, for example, can be used to facilitate or to manage cravings. So that might be a better option than some of the other ones out there. Vyvanse is also a medication that's been approved for treatment of binge eating disorder. So there are, which that's not necessarily an antidepressant, more of an ADHD medication, but there are certain medications that certainly don't have as negative an effect on weight gain.
And just kind of segueing into that as well, like, basically the most important thing is the effect on the patient. Because we do see that even though certain medications are more likely to cause weight gain, in general, it doesn't mean that that's the effect on that person. I have patients who have undergone bariatric surgery, and a big component afterwards is that they can't sleep, they have no energy, they don't have the motivation to continue what they're supposed to be doing along with the surgery. And so, I have patients who've been through that, and the only thing that works is Remeron. They failed multiple other antidepressants or sleep aids and things like that. And so it really is a holistic thing, you have to work on it together. Now, as first line agents, we always try to choose things that will fit with the patient the best. And ideally, if someone comes to you and they're saying, I'm depressed about my weight, I'm depressed in general, I'm having severe anxiety and I'm having all these things, and this is a longstanding thing, you wouldn't choose something that you know might have the potential to worsen the situation. And so you try all of the other options first, but the most important medication is the one that works best with the patient.
Any other questions? Let me check on the chat here if we have anybody. For those of you in the virtual arena, please feel free to ask any questions you'd like as well. So, a question about the mental health of these patients. We see a very high incidence in these patients. And has there been any more understanding of the chicken and egg, phenomenon? Which comes first? Is it obesity that results in mental health problems, or vice versa? What are your thoughts, Dr. Brown?
I think that's a very obviously important question. I don't know that we have a definitive answer, and I think that the research suggests that the relationship is probably more reciprocal, bidirectional, in the sense that certainly we can see patients who have had a history of depression kind of prior to any sort of issues with their weight. And then we certainly see patients, I see patients all the time who will say, it's really my weight that's driving my depression. I've never really been depressed. I've never really had struggles with weight, and these things sort of kind of came together. And so, I don't know that it's clear, and I think it's probably a much more complicated reciprocal relationship.
In the back, yes. Yes, please. And identify yourself, please.
Okay. I'm Sandra Kim. I'm from the Baylor Family Medicine. We do have a large population of the patients who are, I'm sure it's in the down the road in the presentation, the weight loss medication. They will come to us and give me the weight loss medication. Some of them will be, very persistent, not going anywhere. And we all know that this is not just medication, not the only answer. And we would like to have assistance with, behavioral intervention, talking to how do we refer to psychologists who can work with our bariatric or obesity patients who's not going to go anywhere but with us, but we need, how do we refer in the EPIC?
So that's a great question. I see patients within our clinic alone, so I only see bariatric and metabolic patients, either pre or post-operatively. So I may not be a great resource for the patients that you're speaking of. We do have psychiatry, and there are certainly therapists within the Baylor community. Unfortunately, I think there's a really long wait list, and I don't know how many of these providers have the experience or the knowledge to kind of manage some of these weight or eating related issues. And so I think this is a bigger issue, and I struggle with this as well when I refer patients out for therapy. I generally really encourage them to use Psychology Today as a find a therapist tool, and you can kind of specify what you want to work on, and eating issues and weight are potential kind of topics within there. And I think that's probably one of the better resources, and I wish I had a better answer as to how we could kind of keep all of the care kind of within
So your services are after post-surgery?
Yeah, so I see pre and post-op bariatric patients within our clinic.
Is there any other like resources that we can refer to? Because like it's waiting for psychology, psychiatry is a very long list.
It is, yeah, and we actually struggle with that too, and we want to send patients for additional specialist therapy. But by all means, if you have a patient, send us the referral with a comment that what it is that you're specifically looking for, and we might be able to help you there.
So we do like refer bariatric?
Yes.
And then pick you
Yes,
up?
and as you can see, we're establishing a multidisciplinary approach, and we're creating strong links with other departments. So we should be able to help any patient that comes.
Is there any like cutoff point or BMI or any guidelines for referral or just refer?
There are cutoff BMIs for surgery, which are imposed by the insurance companies, but for our purpose, we'll help any patient that has weight-related issues or metabolic syndrome.
Yeah, I second that 100%. I think that the goal is to expand the multidisciplinary team. And so we have several providers in the general and internal medicine clinic who are managing medications. But one of the most important things in the primary care setting is follow-up. And so these patients will want to be put on a med, just say, okay, it's a miracle medicine. I want to see you in 6 months or a year and see how I look. That is not how these medications work. That's not how weight loss works, right? So in my personal practice, I request that these patients see me every 4 to 6 weeks until we've hit their goal BMI. And at that point, we then wean them off the medications, and at the same time, see them every 4 to 6 weeks to make sure that they're maintaining their weight. Because the thing is that some of these medications, yes, like GLP-1 agonists, Wegovy, Ozempic, things like that, they do cut appetite. But if you're going from eating 4 cheeseburgers a day to 1 cheeseburger a day, you will lose weight. But when you no longer have appetite suppression, you're going to regain it immediately. And so when we have these monthly visits or every 2-month visits, we talk about what have you changed, what have you made, done otherwise, and make small tweaks, because this is not a simple situation. This is a lifelong journey.
One last question.
Hi, my name is Laith Matar. Disclosure, I'm Dr. Matar's son. I had a question about the criteria/risk factors for metabolic syndrome. There's a lot of talk about mental health. I'm wondering if something moving forward you'd like to see is a psychological component included in the future.
Psychological component as part of the metabolic syndrome definition.
Yeah.
I think
Dr. Brown, I guess?
I think it would just be really hard to kind of quantify, right? You see how the definition is very numeric. And so, but metabolic syndrome is not just a number, it is the entire person, right? There's so many components to it. So I have a feeling that the definition will always be very numeric, but I do think that that's why we say there's really no BMI cutoff. If people they feel bad, they're not happy where they are, even if they're barely above the upper cutoff of normal BMI, it is important to work together. And whether that's physically, mentally, or holistically, that does need to be something that has to be addressed and worked together.
Perfect. Thank you very much.